Okay, very good afternoon to all of you. My name is Hepsi Natha, Professor and HOD. So today the topic given is to me is viral hepatitis in children. So let us move on to the topic. The outline of the session is we are going to study about what are the various causes of viral hepatitis in children and how to identify them and how to manage the viral hepatitis. Next, what is acute viral hepatitis? So, acute viral hepatitis is the liver inflammation, which is less than 6 months of period, which is said to be acute viral hepatitis. And coming to the chronic, if the same liver inflammation, if it persists for 6 months or more than that, then it is said to be chronic viral hepatitis. And here we have, there are 5 primary hepatotropic viruses are there, which are virologically differ in their characteristics, their transmission and the spread. Those are hepatitis A, B, C, D, and E. And on the other hand, there are other non-hepatotropic viruses are also there, and which are mentioned in this slide. That is cytomegalovirus, parvovirus B19, Epstein-Barr virus, herpes viruses, and other viruses like dengue, adeno, and HHV, etc. So if you talk about the hepatotropic viruses, A, B, C, D, and E, the most common viruses are hepatitis A and E, which is transmitted by fecal oral route. Whereas the other 3, B, C, and D, are transmitted by parenteral administration of drugs, sexually it may get transmitted, or by any of the perinatal routes or modes. So if you the hepatitis D is also called as a delta agent, which is a defective virus where it requires hepatitis B virus in order to cause and spread the co-infection or either the superinfection. So hepatitis A and E is said to be acute viral hepatitis, and hepatitis B, C, and D is said to be chronic viral hepatitis. Next, if you see, as we have already studied that hepatitis A and E is acute, and whereas B, C, and D are chronic. So the most common hepatitis is hepatitis A virus and E virus, which constitutes near about 70 to 80% of all the hepatitis virus, and which all of these may make up into either co-infection or superinfections. So let us talk about now hepatitis A. So there are various viral characteristics of this viral hepatitis A. So this virus is resistant to drying, ether, heat, cold storage, and it may even get denaturated by some of the acidic conditions. And it can also be inactivated by heating the food by more than 85 degrees Celsius or centigrade, and the viral surfaces and can also be treated with 1:1000 dilution of sodium hypochlorite solution in the in tap water. So these are the various viral characteristics where how the virus can be resistant and how it can be inactivated. So if we talk about the pediatric liver disease burden, overall in Indian children, this hepatitis A virus infection contributes at around 72 to 85% of all the acute viral hepatitis cases. On the other hand, 40 to 61% of all the acute liver failure cases constitutes around 40 to 61, and whereas 11 to 42% of all the acute and chronic liver failure cases. So if we talk that what is the main single etiological agent for causing these pediatric liver diseases, we can easily say that hepatitis A virus is only the one important infectious which contributes this much of acute viral hepatitis cases, acute liver failure cases, and all acute on chronic liver failure cases. Coming to the clinical features, so here we have the various phases like incubation phase, prodromal phase, and icteric illness phase. So we know what is incubation phase, the phase where the virus enters into the body and before appearing the signs and symptoms of the clinical features. So it is followed by the other phase, that is prodrome phase, where the child will show some of the clinical features like anorexia, fever, vomiting, flu-like myalgia, and weaknesses. And this particular phase, if turn up into further stage, which is called as an icteric illness phase, where the child will further show the jaundice or dark colored urine, presence or without presence of any itching, all pale color stools, but all the signs and symptoms will get resolved over 1 to 1.5 months, that is around 4 to 6 weeks of period. So these are the various clinical features in each and every phase, that is incubation, prodrome, and mostly we can see the clinical features in prodromal phase and as well as the icteric illness phase. Next is historical evaluation. So what history we have to collect, or what evaluation we need to see when we are collecting the history from the client or the patient. So initially we need to see whether any family member is affected with any of the virus, hepatitis A virus, or if the child get contact with any of the neighborhood contact. So all these things we need to collect the history from them, and any other multi-system involvement is there through any non-classical viruses, like if the child is showing any signs and symptoms of fever, rash, loose stools, red eyes, coryza or cough, or sore throat, or any lymphadenopathy. So maybe these may be the other signs and symptoms which we can not only in the hepatitis A virus, maybe it could be due to any other viruses also. So it is very, very important to rule out which type of virus is causing these type of symptoms. Once if it is ruled out, some specific treatment modalities can be started. Next, let us talk about HEV infection. As I already told, hepatitis A and E infection is very common, and then they both are said to be acute viral hepatitis infection. So this is most of this HEV infection is very rarely have prolonged cholestasis, and there is a good outcome because this HEV infection is mostly seen in the adults rather than the children, and rarely we can see in FHF, that is hepatic failure, and especially it can be seen in some pregnant women, and there is high incidence of asymptomatics we can see, or inapparent HEV infection also we can see. Next, to talk about the CFR, it is around 0.5% to 4%, which is mostly the hospital based, and very less percentage could be seen in case of some population surveys, that is 0.07% to 0.6%. And next is HEV and ACLF. So HEV superinfection and CLD, that is superimposed acute liver injury, can be seen, and there is an acute and chronic liver disease also can be seen in the HEV, because this hepatitis A virus and HEV is mostly together. It will get combined, and it may even leads to the co-infections or even superimposed infections, and there is a higher risk of a poor outcome if it is related with the if it is like in combination with other type of viruses, it may lead to the superinfection or the co-infections. Next, what is the outcome of hepatitis A virus? Most of the cases, like I could say, like 99% of all the cases are self-resolved, where without any treatment, if you give or without treatment also, the child may get cured. 99% of the children will get cured like by self. But in certain cases, in case of some chronic conditions or maybe severity of the virus, there may be chances of liver failure that is less than 1% of the cases will have this liver failure, and other typical manifestations are also there, especially in case of HIV virus, that is prolonged cholestasis, which constitutes at around 15 to 20%, and relapsing course, that is around 5 to 10%, and ascites, that is 13 to 21%, and some severe anemia also could be seen, which is associated with the G6PD deficiency, that is glucose 6 phosphate dehydrogenase deficiency. Next, what are the warning signs in acute viral hepatitis? So if the child will get recovered within 1 month to 1.5 months, that is 4 to 6 weeks of period. But if still the virus is persistent inside the body. If it is not treated on time, there may be chances of turning up into the chronic stage, where there are some of the warning signs in acute viral hepatitis, where it is very, very important that immediate treatment should be started and immediately referral to be done. That is, in case of the child shows some deepening jaundice in case of severe cases, or if the child is having some excessive sleepiness, abnormal behavior, loss of appetite, persistent vomiting, coagulopathy, bleeding from any side. Maybe the patient will, the child may have some fever, seizures, cola colored urine, and abdominal distension. If any of these signs or warning signs, if you observe in acute viral hepatitis, immediate management to be taken. Next, coming to the diagnosis. How do we diagnose the viral hepatitis? So there is some standard workup diagnostic evaluation measures are there, where like LFT, PTINR, USG abdomen should be the child has to undergo all these tests, where all the patients should undergo with the IgM HIV, IgM HEV, and HBsAg, IgM anti-HBC, and anti-HCV. If the above patients or selected patients, if above results is negative, then the child has to go for the other investigations, which may be due to other non-hepatotropic viruses, that may be due to some other non-hepatotropic viruses. So it is very important to rule out this case. Next, coming to the diagnosis. So we could see here, okay, acute infection. So in case of acute and past infection, here it requires IgM anti-HIV antibody testing, which is very important. And this can be detected in serum within 5 to 20 days following the exposure to the virus. And it remains positive for around 30 to 420 days, which is an average of 4 months. So we can easily make out that the patient is having some acute infection. Whereas the past infection or previous immunization, if the child has already taken, then it is associated with serum IgG anti-HIV antibodies, where the child will have a long-term, lifelong immunity. Okay, coming to the management. So the general treatment of it is like, especially reassurance is very, very important, where the parental and doctor's reassurance regarding the condition is very important. The child can encourage for the normal diet, and encourage the child to have a plenty of fluids, and there is no medications needed in majority of the cases, where it can resolve by its own without any sort of medications or the treatment. Coming to the do's and don'ts, so no restriction on diet, healthy diet can be given, and there is no much bed rest is also not needed, and bland food, restriction of salt, fat, spices, turmeric. There is no need for restriction of this bland food. Okay, next, herbal medications, like many of some misconceptions are there, like in case of hepatitis, these medicines should not be taken, or this food should be taken, or something like that. So there is no such restrictions, like herbal medicine intake is not necessary. Glucose or water, sugar cane juice and all intake is also not necessary. So do's and don'ts: no restriction on diet, no bed rest needed, and bland food, restriction of salt, fat, spices, turmeric should not, and herbal medicine intake, glucose, water, sugarcane juice intake also is not necessary. Next, coming to the specific treatment. So antiviral treatment should be given, especially for hepatitis B, and it is needed in less than 5% of the cases only. And what are the indications of this antiviral treatment, especially ALF, that is acute liver failure, or severe acute hepatitis B, where the INR is less than 1.5, or a protracted course, that is persistent symptoms of marked jaundice for more than 4 weeks. And other viruses also, where the treatment can be started in case of varicella, CMV, and HSV cases. And next, antiviral measures in case of HEV virus, that is, there are some medications where we can give, that is use of pegylated interferon, ribavirin, or both in chronic HEV infections, because it is due to associated risk of progressive liver injury. Hence, these drugs can be administered to the child, and it may lead to cirrhosis after which is less than 3 years of infection. It may furtherly leads to leads to cirrhosis of liver, and most of the case reports or small case series have been conducted for this type of viruses, and that is about acute viral hepatitis. We have studied about hepatitis A virus and E virus. Now let us study about chronic viral hepatitis, that is hepatitis B, C, and D. So when we talk about the key facts, in India, there are around 10% to 15% of the global pool, that is 400 million HPV carriers are there. And according to WHO in 2019, there were 296 million are living with hepatitis B, and 58 million were living with hepatitis C, and around 1.5 million newly infected cases with chronic hepatitis B, and the same with chronic hepatitis C. That was given by WHO in the year 2019. And if you see globally, mostly it is like low intermediate, that is around only 2 to 4% of the people are suffering from the hepatitis B worldwide, and in case only hardly 1% or 1.5% of the population are suffering with the hepatitis C prevalence. So the main routes of transmission of hepatitis B, C, and D is through perinatal, sexual, and other routes also are there. So in perinatal, you can say that mother to baby, that is vertical transmission of virus will be there, that is during parturition or immediately after birth. So the major route in the developing world, including India and other Asian sub-Saharan Africa. So perinatal transmission will be there, that is mother to baby, that is vertical transmission is present in this hepatitis B virus, and other causes are also there, like sexual transmission. So the major route is sexual transmission in the developed world, especially in the Western countries, that is USA and Europe, and other routes are also there which may lead to this, which causes this hepatitis B virus, that is injection drug use, maybe due to blood transfusion, or it could be due to hemodialysis. So how the hepatitis B virus does not spread through? It does not spread through food or water, sharing and eating utensils, or it does not spread through breastfeeding, hugging, kissing, hand holding, coughing, or sneezing. That we should clearly know. This is only through either a sexual transmission or perinatal mode transmission or other parental route transmission, but not through any of the food or water or whatever, breastfeeding, coughing, or sneezing. Any of these routes it will not spread or transmit. So who are the high-risk groups who are affected with this hepatitis B virus? So the high-risk groups are the infants who are born to infected mothers, or the sex partners of infected persons, the men who have sex with men, that is like homosexuals, or infection drug users, and the household contacts of the known people already with chronic hepatitis B virus infection, maybe healthcare professionals who are continuously with the patients who are infected with the virus, and mostly the hemodialysis patients. So these are the high risk groups in which the hepatitis B virus will be easily transmitted to. And here there are various stages of HBV infection. Here we have 4 stages. So especially the main treatment response will be there in the second stage, that is 10%, that is 10% of the child, especially in the second stage, that is immune clearance, HBV positive chronic hepatitis, where the best treatment response could be seen in the second stage, whereas in the other stages like starting immune tolerant stage or inactive carrier stage and other stages, there is no treatment required for this HBV infection, but it is the treatment will best response or treatment response could be seen only in the second. So that is only minimum, that is 10% of the cases could be best respond to the treatment, that is immune clearance HBV positive chronic hepatitis. Next, now let us see the natural history in children. So mostly perinatal transmission, as we've already seen, that is perinatal transmission, mother to child, that is vertical transmission. So let us have a look here about the risk of chronicity as per age of acquisition. So if you see, if the infection if the in during infancy, if the infection during the infancy, majority of the person is more than 90%. If an infant get affected with this virus, so 90% of the infection will be present throughout the lifetime. And in case if 1 to 5 years, the virus, the 25 to 50% of the chances are there. 25 to 50% of the infection will be present. And if age is advancing, that is more than 5 years, automatically the severity of the virus will be decreased in the body, that is near about to 5 to 10%. So as the age is increasing, the severity of the virus will be decreasing. That's how this risk of chronicity as per age of acquisition. And next, coming to the seroconversion rates. So in mostly in Asians, there is a perinatal transmission, and in case of Europeans, it is horizontal transmission. So as the age is decreasing, even the percentage is also decreasing. So less than 3 years of age, only 2% per year, whereas if it is more than 3 years of age, automatically it is 4 to 5% per year. That is in case of perinatal transmission, whereas in the horizontal transmission, near about 70 to 80% over the year, 20 years of age. In case of adults, when the age is increasing, automatically the virus, the liver also will get affected. In case of children, when the age is when the age is advancing, the percentage of virus also will be decreased or minimized. Next here, when we talk about the childhood to adolescence, if there is HPV infection to the infant, if it is affected to the infant, so there is an inapparent disease which may be either recovery will be there or as chronic infection. So recovery will be less than 10% will be there, and whereas in case if it is a chronic infection, if it is more than 90% of the cases, it may turn up into either chronic hepatitis or inactive carrier. So in case if it is a chronic hepatitis, near about 30 to 40% of the cases from chronic infection, it may turn up into the chronic hepatitis, where there is severe liver inflammation damage will be there, and it may leads to compensated cirrhosis of liver, and further it may leads to decompensated cirrhosis and hepatocellular carcinoma, and finally if the person may even die. But in case if on the other hand, if it is if it is an inactive carrier, that constitutes around 60 to 70% of the cases, very minimal percentage of the cases may turn up into the hepatocellular carcinoma. That is very 0.1% is very negligible. But in case if it is like chronic hepatitis, the person may turn up into the cirrhosis of liver, decompensated cirrhosis, and finally cancer, and even the patient even may die. Okay. Next is family screening. Here, the family should be screened with these three important things. That is, the family has to screen with HPSAG, anti-HPSS titer, and total anti-HPC. So, based upon the result, that is either it is positive or negative, so it will be decided whether the vaccination should be given or not given. So here, in case if it is positive, how many units of anti-HPS to be given, and what is the status of whether it is exposed or not. If exposed means vaccination to be given. If it is negative but unexposed, unimmunized, so offer vaccination. So like that, if the result is positive or negative, depend based upon the type of virus it is exposed. So further investigation to be done, and whatever vaccination is required furtherly, it has to be the person has to be immunized. So next, HCV infection. So mostly it is vertical transmission. So 20% of the clear infection without any treatment, that is within first 2 to 4 years of life, but remaining 80% may turn up into the chronic infection. So initially, if a child is around 2 to 4 years of life, there is no such treatment being given to the child, because automatically the infection gets subsided. But they will wait, and we can wait, and that is near about 20%. But whereas on the other hand, near about 80% of the cases, if it is not treated or if it is not subsided, automatically it will turn up into the chronic infection, as HCV infection is a chronic type of virus. And coming to the lab diagnosis of HCV virus, So three important diagnostic evaluations are that is anti-HCV antibody, HCV RNA, and HCV genotype based upon the type of virus. Coming to the treatment of HCV virus. So in case of acute or chronic hepatitis C virus infection, either it is in a child or adolescent. So mainly we have to see for the presence of any rapidly progressive disease. It could be either cirrhosis or HIV or HBV co-infection. If it is, if any of these rapidly progressive diseases are present, if S, so immediately the child is to be referred to a specialist in HCV for consideration of special protocols used for patients with this profile. Where if there is no presence of any of these infections, and we have to check for the patient's age. So if it is less than 3 years of age, we can defer the treatment. It's not necessary. We can wait for the child to go within more than 3 years. If the child is more than 3 years, then we can treat with the drugs which is given in the slide, that is treated with any of these like sofosbuvir, veltapsavir. So there are various type of drugs being given here, and it is based on any genotype. Any genotype here they have given genotypes like 1, 4, 5, and 6. So genotype is a type of uh, that virus. Based on it genotype or of that particular virus, the particular drug will be administered to the patient to relieve from that particular infections. Next, coming to the prevention. So we have to check, especially in case if it is any doubtful vaccination history, we have to go with the anti-HBs titers, anti-HIV total or IgG. Then the children, there are child who is more than 5 years of age. And family screening is also very, very important in case of HBV infection for HBsAg, anti-HBc total, and anti-HBs titers. And how to prevent of HBV. So HBV vaccination is very, very effective. Mostly here commercially available are hepatitis A and B vaccinations. Okay, so NFHS, that is around 66.3% coverage for all the 3 doses. So this is very, very effective. Hepatitis B vaccination is there, and maternal screening should be there for HBsAg, and we need to encourage for safe sex. And next, do not share the needles, because it is also one of the important cause, especially for the healthcare professionals, that they will be affected with this HBV virus, and all the healthcare workers to follow all the universal precautionary measures to prevent the transmission of this HPV virus. And here, so in case of pregnant women, HBsAg testing is very, very mandatory. Serological testing, if she is positive or negative, then we have to assess for the maternal prophylaxis or a long-term treatment. So based upon her, like if HBV DNA viral load or HBsAg is should be, and we have to assess for any presence of cirrhosis, whether it is present or whether it is not present. So based on it, the units which are mentioned in the slide to be given, and after that we have to start the maternal interventions. So if there is no maternal tenofovir prophylaxis is there, or else either you can start with a defer, that is long-term maternal tenofovir treatment, but it is very, very mandatory to monitor and reassess as per the WHO guidelines that is given. And in case in the second, like if more 2 lakhs international units per ml, if it is given in case of HBsAg positive but without cirrhosis, without presence of cirrhosis, then you can start maternal tenofovir prophylaxis from 28 weeks of pregnancy until the last at least till the birth. This has to be given, that is we have to start the maternal tenofovir prophylaxis, and after that we have to reassess for long-term maternal tenofovir treatment even after delivery and monitor for the symptoms. And then next is, if there is presence of cirrhosis, like first we have seen without cirrhosis of liver what to be done, and if there is presence of cirrhosis, so what we have to do, we have to start the long-term maternal tenofovir treatment and monitor as per the WHO HPV treatment guidelines. That is about the maternal intervention in presence of cirrhosis and without cirrhosis. And last is like if next after birth, what to be done, that infant interventions to be taken. So hepatitis B birth dose vaccination of the infant followed by 2 or 3 doses of vaccine should be given. And then for infants, if the infants born to HBsAg positive mothers, especially if HBeAg positive or with high HBV DNA, then you have to start the treatment. This is the testing in pregnant women, how to assess and how to start, what are the various maternal interventions and infant interventions. Then, effect of elective cesarean section on the risk of mother-to-child transmission of hepatitis B virus. So, with recommended immunoprophylaxis against hepatitis B, so elective cesarean section does not reduce the risk of mother-to-child transmission of HBV. Like most people think, okay, through normal perinatal mode, like there may be chances of vertical transmission from mother to child. So better to go with the elective cesarean section so that we can prevent the transmission, but it's not like that. So therefore, ECA should not be used in HBsAg positive women, pregnant women, to prevent mother to child transmission of hepatitis B virus. The same likewise like breastfeeding and risk of HPV transmission. So there is no such differences in hepatitis B vaccine transmission regarding the feeding practices. Even in cases of no active or passive prophylaxis, the risk of transmission from HPV positive mothers to the breastfed infants is at least equal. There is equal. There is no such things like if the mother is suffering from this positive, so so we cannot say that you don't breastfeed your infants. It's not like that. Next, coming to hepatitis A. What are the various strategies for hepatitis A? So, adequate food and need to maintain the water hygiene. Next, there is a passive prophylaxis with immune globulin that is only for children who are less than 12 months during infancy and who are immunocompromised host, those with chronic liver disease or in whom vaccination is contraindicated, or within 2 weeks of exposure or limited practical. So this is a passive prophylaxis should be with immunoglobulin can be given only for the children who are less than 12 months, who are immunocompromised and who within 2 weeks of exposure or limited practical exposure. And there are various vaccination options. So available vaccines are like important two types, that is a killed vaccine and live attenuated vaccine, and it can be given more than and equal to 12 months of age. So that is killed is formally inactivated, where it can be given intramuscularly, and 2 doses at 6 months interval need to be given. Whereas live attenuated, it is a single dose and the route will be subcutaneous. And the efficacy, excellent efficacy is there, that is more than 90 to 95%, and which is recommended by IAB, that is Indian Academy of Pediatrics. And other vaccination strategies, we have to check, especially if there is any doubtful vaccination history. So need to test for anti-HIV total or IgG if the child is more than 5 years of age, and to avoid vaccinating those with natural immunity. If they have natural immunity, better to avoid those vaccinations, and no vaccine needed if there is positive results. So this should be very much importantly remembered. And coming to the significance of vaccination against HIV infection. So if we see what is the significance of vaccination, that is very important against this HIV infection, especially in case of endemic pattern previously, because of due to poor hygiene or sanitation, and due to of overcrowded population, infections and immune minority population, they are more susceptible to have this sort of affected with the HIV virus, where it is very prevalent all over the area, where the people will get infected and finally they will get long-term immunity. So for them, there is not necessary, there is no need for the vaccination. And as present scenario, like ongoing epidemiological transition in India. So due to proper improved sanitation, or due to decreased HIV transmission or low immunization coverage, or maybe because they may be above middle class or rich class, where where there may be minimal exposure to the virus, and where even here also there is necessary of vaccination. But if you see this epidemic pattern where nowadays, due to improved hygiene, improved sanitation, where there is high immunization coverage, where there is vast majority vaccination drives are available, and immune minimal susceptible population, because they are not exposed to the virus. So hence there isn't there is very much important for them to get vaccinated with the HIV infections. Coming to the summary, as we have already seen, the hepatitis A virus constitutes around 38 to 55% of all the cases, whereas hepatitis Z is 7 to 16% and B is 17 to 14%. And with that co-infection, it could be along with the A, B, A, E, or AB, it leads to 8 to 26%, and unknown viruses, that is around 23%, which may to 11 to 35, 3.5%, and even 0%. So this is how the percentage distribution as per the virus. Coming to the learning points, always exclude hepatitis A, E, and B virus in all the acute viral hepatitis cases, and also do anti-hepatitis C virus, whether in case of silent or chronic cases. It is very important, and complete evaluation in all co-infections, because it may lead to further, it may turn up into further chronic infections. So test for other viruses like serology or PCR if in case of acute liver injury, and plus negative classical serology, and choose as per the clinical picture based on the signs and symptoms. And last, carry home messages. Here, HIV and HIV virus is the commonest cause of acute viral hepatitis infection, and the workup not to be limited to HBsAg or anti-HCV only. And whereas the management of acute viral hepatitis is like no dietary restrictions, or there are no medications to be given, where it can be subsided within 4 to 6 months, resolved within 4 to 6 weeks or 1 to 1.5 months. And reassurance is very, very important from the parental side and as well as the doctor side. So pick up HBV or HCV early, screen family and high risk groups, so that we can prevent the further infections. So we can prevent acute viral hepatitis and as well as the chronic viral hepatitis. Thank you so much.